friends, today we'll be talking about TMDs. Okay, this is a part 1 video in which we'll be talking about case history and examination, classification of TMDs, and briefly we'll be discussing derangements of condyle-disc complex. Here we'll be talking about case history and examination, but before we move on with it, let's see the normal positioning of the condyle and articular disc and the mandibular fossa. Alright, so here in this picture we can see when the mouth is closed how condyle, articular disc and the mandibular fossa is placed, okay, when in rest. Coming to the history taking, first when the patient enters the clinic, okay, make him sit, relax and ask for his chief complaint. Okay, so the chief complaint should always be recorded in the patient's own words. Okay, so you have to understand the location of pain, where exactly the patient is having pain. All right, and if is experiencing any pain in other areas also. All right, the duration of pain, when the pain has started, okay, since how many months or days he's been experiencing pain, whether he's experiencing pain every day or there are some days when he has no episodes of pain. All right, then you have to ask him or her when the first pain first began. Okay, maybe it is associated with any event. All right, maybe he had a trauma, or maybe he had a pain when after a dental treatment. Okay, and if he has any pattern over noticed any pattern over a period of time when there is remission in the pain, or when there is any thing that he has done that has aggravated the pain. Okay, and how often does he get this pain episodes? Okay, whether the pain is continuous or it's been there every day. Okay, then you have to ask him what time of the day does he experience this pain. All right, maybe if he has any parafunctional habit like night grinding, he might have pain which is aggravated in the morning. Okay, but as the day progresses the pain is relieved. Okay, so when the pain is worst, you have to ask all those questions. Okay, then you have to ask for aggravating and relieving factors. So it might be patient might say that yeah, I have pain which aggravates or which increases when I try to open my mouth wide. Okay, or during yawning or chewing or speaking. Okay, or during any postural positions that may aggravate the pain. Relieving factors can be taking rest or taking any analgesics. Okay, then ask the patient whether he has pain in other areas, like if he has any headache or earache, okay, or any cheek pain that he has noticed, and when the pain starts, okay, and when it worsens. All right, and if he has any dental pain, okay, any tooth pain is there, or if he has any sensitivity in any teeth, or when the pain aggravates on biting anything hard substance on the teeth that can cause pain. Okay, then if he had heard any joint noises, okay, like opening the mouth, if he has any clicking or popping sound he has heard, okay, or if the jaw movements feel restricted, he might say that okay, at certain point I can open my mouth, post that I start feeling pain. Okay, or whether he had any history of trauma, he might have met with an accident. Okay, or he would have had a direct blow on his chin, maybe he had fallen down. Okay, so if he has any of such changes which has caused the pain. Other than that, ask him if he can close his mouth properly. Okay, all his teeth meet or the occlusal discrepancy is not present. Okay, sometimes even the eruption of third molar can cause this jaw pain. All right, and if he has taken any treatments previously, okay, and what were the treatments he has taken and how much relief he has got after taking such treatment. All right, other than that, you have to ask him if he has any parafunctional habits, like if he has any night grinding, or when he gets angry he's clenching his teeth really hard. Okay, if he has taking any dental treatments previously, it could be that the crown, if he has gotten placed and it's not fixed properly, it also, or he has any high point post filling, it can cause pain. Okay, if he has been sleeping properly, sleep disturbances will also result in TMDs many a times. Emotional stress, okay, all such things you have to ask in the case history to understand if the patient has any problems that has caused the TMDs. Okay, other than that, if he has any other body pain in the other parts, okay, if he has any other complaints, if he has any past medical history, we might have arthritis which has caused TMDs. Okay, so all medical history also you have to know. Okay, you have to check him thoroughly, review all his systems. All right, and you have to have a psychological analysis also, because stress, emotional stress, and your sleep disturbances will also cause TMDs. Got it? With the examination of temporomandibular joint. First of all, if the patient complains that till certain point I can open my mouth, post that if I try to open my mouth wide, I am having pain. Okay, measure the mouth opening. At what point he has pain and at what point he doesn't have, or he doesn't is not experiencing any pain. Okay, so mouth measurement of mouth opening is very important, with pain and without pain. All right, then standing in front of the patient, ask the patient to slowly open the mouth and close the mouth. That way you can see if there is any deviation or deflection. Understood? Then stand behind the patient, ask the patient to relax, keep your fingers in front of the ear, okay, and you can actually feel the joint. Okay, now ask the patient to open the mouth slowly and close. That way you can hear if there is any clicking which is present, or if there is any popping which is present. All right, that's how you'll do the examination of temporomandibular joint. Now coming to the classification, according to Okerson, it is classified as masticatory muscle disorders, temporomandibular joint disorder, structural incompatibility of articular surface, and inflammatory disorders of TMJ. Other than that, chronic mandibular hypomobility is also classified, and then there are growth disorders. Okay, so in the masticatory muscle disorders, it's protective co-contraction, local muscle soreness, myospasm, myofascial pain, and centrally mediated myalgia. Okay, in TMDs, we'll be talking about derangements of condyle-disc complex like disc displacements, disc dislocations with reduction, and disc dislocation without reduction. Okay, the structural incompatibility of articular surfaces will have deviation in form of condyle, disc, and fossa, adherence and adhesions, disc which are of disc to condyle, disc to fossa. Okay, then we'll be talking about subluxation and spontaneous dislocations. All right, and the inflammatory disorders of TMJ consist of synovitis and capsulitis, retrodiscitis, arthritis, alright, and other inflammatory disorders of associated structure like temporal tendonitis, tylomandibular ligament inflammation, etc. The chronic mandibular hypomobility will show ankylosis, which can be fibrous or bony, muscle contractures like myositis, myofibrotic, okay, and coronoid process impedance. So, growth disorders could be congenital or developmental, like agenesis, hypoplasia, hyperplasia, any neoplasias. Okay, and congenital and development muscle disorders also could be present, like hypotrophy, hypertrophy, neoplasia, which will cause this TMDs. All right. So, in this lecture, we will be specifically discussing about derangements of condyle disc complex. Let's talk about the derangements of condyle disc complex. We all know condyle disc complex is nothing but the head of the condyle, when attaches into the mandibular fossa, there is a disc which is present, which prevents the friction of these two articulating surfaces. Okay, now derangements occur when there is a breakdown in the normal rotational functions of disc of the condyle. Okay, now this could be due to elongation of discal ligaments or inferior retrodiscal lamina, or because of thinning of the posterior border of the disc. Now this could occur due to various reasons like trauma. Now trauma can be macro trauma due to parafunctional habits, or macro trauma, that is the trauma which occurs because of accidents or because of sustaining fall. Understand what is disc displacement. Okay, so if you see in the picture A, you will notice that the disc is at the normal position, okay, where the central zone of the disc lies or is attached to the condyle. Okay, posteriorly you will see that there is a retrodiscal lamina which is present. All right, and at the neck of the condyle you will also see collateral ligaments. All right, anteriorly if you see, the disc is attached to the superior lateral pterygoid muscle. Now what happens in the normal position? When the mouth opens, the condyle moves but with the disc. All right, so the movement is towards the anterior portion of the, or anterior border of the disc. All right, now in disc displacement, basically what happens is, because there is elongation of retrodiscal lamina and your collateral ligaments, all right, there is a superior lateral pterygoid muscle which is pulling the disc anteriorly, and because of this constant pull, what happens is the posterior border of the disc becomes thin. All right, now because there is a constant pulling, the disc has moved anteriorly and is positioned anteriorly, and because it's constantly present anteriorly, the posterior portion of this disc becomes thin and the condyle starts resting on the posterior portion of the disc. So when the mouth basically opens, there is an abnormal condyle disc complex which has formed. Correct? Because the disc has moved anteriorly, the condyle is resting on the posterior border of the disc and the translatory motion completely shifts. Okay, because of that there is opening click which is present. Okay, so when there is a mouth opening, the joint will have a click, a single click which is present. Sometimes there is a double click which is present, or opening or closing click which is present, which is known as a reciprocal clicking. So to understand what has happened here is, because the disc is constantly present anteriorly. Why is it present anteriorly? Because of the superior lateral pterygoid muscle pull. Correct? Why the muscle has started pulling it anteriorly is because of elongation of inferior retrodiscal lamina and discal ligament or collateral ligament. All right, so because the disc is positioned anteriorly all the time, the posterior border of this disc lies in the with the condyle, and because of that the posterior border has started to thin. Okay, so when in resting position, the condyle rests on the posterior portion of the disc. So while opening, there is an abnormal translatory shift which is occurring. Okay, which is associated with abnormal condyle disc movement, which results in clicking. Okay, now this occurs because of trauma. All right, if you see clinically, pain may be present or may not be present. Okay, if it is present at certain point of mouth opening, it is which causes limitation of mouth opening, it is because of the it is not because of the structural dysfunction. Okay, it is because of the pain. Why pain occurs? Because you know the posterior border of the disc is highly vascular and has good nerve supply. Correct? So when it starts to thin, it's going to impinge on the nerve, which is going to cause the pain. All right. So in the discal displacement the thing which you are going to see is clicking sound. Okay, it could be a single click or it could be a reciprocal click. So now when the reciprocal click is present, it's because the two clicks normally occur at different degrees of opening, with closing click occurring near intercuspal position. Got it? Okay, now let's learn about the disc dislocation. Now we understood in disc displacement that because the inferior retrodiscal lamina and collateral ligament had elongated for longer period of time, there was anterior pull of superior lateral pterygoid muscle, correct? The disc had positioned itself anteriorly. So condyle was lying on the posterior border of the disc, which resulted in thinning of the posterior border of the disc. Correct? Now in disc dislocation, what happens is, because this process is prolonged or is there for a very long period of time, the is elongation of inferior retrodiscal lamina and collateral ligament, correct? The disc is positioned such that the condyle rests on the posterior border of the disc. There is sufficient thinning of the posterior border of the disc that has occurred. Now whenever patient opens the mouth, the disc slips out of the discal space. Okay, so the condyle no longer articulates with the disc, and that is nothing but your disc dislocation. Okay, now why the name disc dislocation with reduction? So now what happens in this is, the patient can manipulate the jaw such that he can reposition the condyle on posterior border of the disc, and that is said to be the disc is reduced. Alright, and history itself says that there has been, for longer period of time, the click sound was present, okay, on opening. Now from some time the patient is also experiencing catching sensation, that is the jaw gets stuck, okay, when patient is trying to open the mouth. Alright, and then patient can manipulate it and bring it back to functionally becoming normal. Okay, so in this case patient may have pain, may not have pain. Alright, and other than that, there is limited range of mouth opening, noticeable deviation in the pathway, pop sound is heard, okay, and in many cases keeping mouth in slightly protruded position after recapturing disc will eliminate the catching sensation during opening and closing. Okay, now in such cases you have to give the stabilization appliances. Alright, disc dislocation without reduction. So what happened, we understood that there was elongation, okay, in the retrodiscal lamina and your discal ligaments, correct? The disc was positioned on the anterior side or in the anterior region, so the condyle was resting on the posterior border of the disc, correct? Now with reduction, with reduction, what had happened was, when the disc had completely popped out of the discal space, the individual could actually manipulate the jaw and bring back the disc, okay, such that the condyle was again resting on the posterior border of the disc. Now without reduction, what has happened is, there is no recapturing of this disc, because the ligament has elongated so much that the elasticity is lost, of elasticity of retrodiscal lamina is lost. So there is no recapturing of this disc, it becomes very difficult. So in such cases what happens is, the patient have limited mouth opening, okay, because whenever now the disc which comes out of the discal space lies in front of the condyle, so mouth opening has become limited. Alright, and the history states that it is because of the event like a trauma, okay, and history also reveals that clicking occurred before the locking, but not since the dislocation has occurred, okay, and pain can be associated with this condition. Other than that, range of mandibular opening or mouth opening is only 25 to 30 mm, okay, deflects to the involved joint. Alright, there is a deviation or deflection towards the involved joint. The maximum point of opening reveals a hard end feel. Okay, so when you try to open the mouth, you will feel the resistance. Okay, eccentric movements are normal on the ipsilateral side but restricted on the contralateral side. Okay, the treatment is basically joint manipulation. Understood? Thank you. Please like, share, subscribe, and if you want any other topics, do let me know in the comment box below.